Jessica, I've been looking all over for you.
What? Is it your back again?
It's killing me. I need a prescription. Look, please, just one more time. I won't ask you again.
Well, that's what you said last time. Look, you've been on hydrocodone for, what? I mean, at least a couple of months now that I know of. I mean, this is a very addictive painkiller. I mean, I don't have to tell you this.
Just one more time, Jessica. I promise, just one more time. I can handle this, but I can't make it through without some help. Please, Jessica, I'm dealing with it. I mean, there's no problem. Believe me, I can handle it. For God's sakes, come on. I'm a doctor.
Look, what I'm doing, I just don't think it's in your best interest.
What are you so worried about? Do you think I'll become addicted? Do I look like an addict? Do I act like an addict? This is back pain. I just need something to get me over the hump.
Okay, all right, but just one more time, and then no more. And I know I've said that before, but I really mean it this time. No more.
Thanks. I really appreciate it.
Here, we have all the ingredients for disaster in the making. A resident on the way to full-blown addiction, if indeed he's not already arrived at that point, and a well-meaning colleague who's in the process of enabling his misuse or abuse of a drug.
Jessica is dealing with a friend who has a problem, one with significant ramifications for his personal life, his professional friendships, and his career. Her friend's problem has ramifications for her career as well, and could lead to a disciplinary action by a medical board or even the Drug Enforcement Administration. What should she do? What would you do in a similar situation?
Let's back up and see how Jessica might best deal with this situation.
Look, what I'm doing, I just don't think it's in your best interest.
What are you so worried about? Do you think I'll become addicted? Do I look like an addict? Do I act like an addict? This is back pain. I just need something to get me over the hump.
Look, John, I'm saying this to you because I'm your friend. I'm concerned. You're beginning to act and sound like somebody who may be addicted to a drug. I mean, and just because you're functional at work doesn't mean you're not addicted.
Don't be silly. You're making a big deal out of nothing. I just want a few pills for back pain.
Well, then go see a doctor. Stop asking your friends. I mean, I'm not doing you or me any favors here if I do this. I think sometimes doctors forget that they need doctors too. I mean, right now you need to be a patient and go see a doctor. I mean, my giving you this prescription is only going to stand in the way of you getting the help that you need. And I'm not going to do that. And if you don't take this first step, then I'm going to take it for you and let the program director know. I mean, that would be an act of true friendship.
You know what? I'm sorry I asked.
Historically, physicians have been reluctant to get involved when their colleagues manifest symptoms of impairment unless patient safety is at risk. But the potential impact of substance abuse, whether abuse of alcohol, prescription, or illegal drugs, is significant, even if the quality of their medical care has not been compromised yet. This segment of the LIFE program has been designed to help you recognize symptoms of substance abuse and to intervene effectively so that your residents can get the best help and treatment available.
Studies estimate that in the U.S., the prevalence of chemical and alcohol abuse for physicians is similar to that of the general public. About 6% suffer substance abuse disorders, and approximately 14% suffer from an alcohol use disorder. Alcohol is the number one substance that is abused, followed by opioid analgesics, amphetamines, barbiturates, cocaine, and marijuana. The risk factors for substance abuse in physicians are also similar to those for the general population. Substantial percentages of both physicians and medical students report stress at work and home, emotional problems, self-treatment of pain, sleep and fatigue, psychic stimulation, and family histories of substance abuse. Perhaps the most important risk factor for physicians is their easy access to pharmaceuticals either through diverting sample medications, self-prescribing, falsifying prescriptions, or obtaining prescriptions from colleagues.
Unfortunately, early detection of physician addiction is difficult. Addicted physicians can continue to function at high levels for a long time, and their problem is usually identified at a later stage, when their performance becomes markedly impaired. Work is usually the last area in their lives to suffer. Alcohol addiction is especially hard to determine. Not only is alcohol a legal substance, but its use is socially acceptable and even encouraged through medical traditions such as liver rounds. The difficulty resides in separating use from misuse or abuse. Most commonly, a physician's alcohol abuse is identified as a result of complaints. A typical situation is one or more phone calls from others, either colleagues or family members of patients, reporting a suspicious odor of alcohol detected on a resident's breath. Although such an allegation is not a confirmation, it should be taken seriously and prompt a thorough evaluation.
There are early signs of any substance abuse that should raise the index of suspicion. Signs include alterations in professional behavior, dress appearance, and changes in behavior. For example, a punctual person is routinely late for appointments. Signs also include any cavalier prescribing of controlled substances. For example, any resident who prescribes a relatively large quantity of opioids for a patient with a self-limiting condition needs careful evaluation. Deterioration in personal life or in family relationships may be more subtle and difficult to detect. While substance abuse certainly affects both, unless the spouse or significant other is forthcoming with information, abuse will probably unidentified unidentified until work function begins to decline or social legal problems result. A DWI and other repeated traffic violations, speeding tickets, or reckless driving, for example, are significant red flags.
Identifying doctors at risk is difficult for a number of other reasons. Denial of addiction can be considerable. In our medical culture, it's often hear no evil, see no evil, speak no evil, and maybe the whole thing will just go away. Denial occurs on all levels: the institution, the resident, peers, and the family and significant others.
On the institutional level, as we saw in the first part of our scenario, colleagues or even supervisors, for that matter, can become enmeshed in a conspiracy of silence. They may make excuses for a colleague's behavior and dismiss the accuracy of their diagnosis or intuition. They may even fear retribution if they come forward and share what they know. As well, they may be sincerely afraid of causing legal problems. They may believe, like most others in the general population, that physicians either don't get ill or that they are able to heal themselves. They may also fear risking a friendship, alienating a person they value. More critically, they may be afraid that reporting a colleague's addiction will end his or her career. Unfortunately, many professionals remain unaware of the potential resources which allow physicians to continue to practice after getting the treatment help they need. Denial also exists on the level of the addicted individual. So entrenched are their defenses that addicted doctors may be unable to recognize that they even have a problem. Family members and friends may feel a great sense of failure with respect to the person's addiction because they are unable to either rescue the person or convince that person to get the help they need. They may also be dependent on the physician's salary and fear losing it if he or she enters treatment. The peer relationship is particularly complex. They too may feel failure because of an inability to get their colleague the needed help. But they also may be involved by being asked to write prescriptions for their colleague.
I just don't get it. And I don't do pot, I don't drink, I don't smoke. But sometimes, in order to work, I use opiates. So what? And I have a bad back and they help. They help me get through the day. And I take good care of my patients. Nobody ever questions I'm a good doc. They haven't caused me any problems. And I haven't escalated my use. I can handle them. If I had a glass of wine or a bottle of beer, nobody would say anything. And look at my department. They have liver rounds every Friday night. So what's the big deal?
Even when residents recognize that they are alcohol and/or drug dependent, they often believe they can deal with it on their own.
I can stop anytime I want. I'm functioning at a really top level, at peak performance. So why is this a problem? And why do people try and make me feel guilty for something that isn't doing me any harm?
If denial exacerbates the problem of dealing with addiction, so does a punitive approach.
Traditionally, substance abuse has been treated as though it were a moral or ethical failure instead of a disease. Physicians who became addicted faced extreme disciplinary measures, including the loss of a medical license. As a result, doctors who desired treatment faced substantial hurdles. Now, addiction is viewed as a disease. There are medical societies and programs in every state designed to help physicians deal with substance impairment.
All institutions should have a clearly articulated administrative and therapeutic pathway to deal with this issue. The administrative pathway requires defined policies and procedures outlining the steps to be taken once a resident or other physician with a potential substance abuse problem has been identified. Hospital bylaws constitute one mechanism that can spell out acceptable versus unacceptable behavior, the necessary documentation needed to avoid legal exposure, and the consequences, or due process, if you will, if those bylaws are violated. All should be treated the same, and all should be offered help.
The therapeutic pathway consists of physicians and/or programs in the area that can provide substance abuse treatment once the resident with alcohol or drug-related problem has been identified.
In residency programs, if a physician is aware of a resident who has an alcohol or drug problem, the program director should be contacted. The program director can, in turn, access the appropriate resources. These may include the Medical Society or Physicians Health Program or their system's employee health service. The Physician Health Program protects physicians' confidentiality and will clear them to return to practice once initial treatment is completed. Residents should not hesitate to contact the program director because of a misguided sense of loyalty to their colleague. Contact should be made as soon as possible.
Hi, Jessica.
Hey, Dr. Beck.
How are you?
Okay.
And what brings you in?
Well, it's about John. It all started a few months ago when he injured his back, and he's been taking hydrocodone. This is really hard for me to say, but I think he might have a problem. I don't want to be part of the problem. I want to be part of the solution. So I think he needs your help.
Well, you've done the right thing. I'll talk to John, and we'll see about getting him evaluated by the Physician Health Program. If he is addicted, I would imagine they'll recommend inpatient treatment. If so, I'll arrange for a medical leave of absence for him. We'll all pitch in and help. I know this is tough, but I appreciate you coming in, and so will John.
Okay. Well, thanks.
The obligation to report an addicted colleague has both legal and ethical dimensions. In some states, the law requires that substance abuse be reported. Physicians who have substance abuse problems risk harming a patient, and patients must be protected from even potential harm. Similarly, professional ethics require physicians to help addicted colleagues. If residents aren't appropriately identified and successfully treated, they risk an inevitable loss of license and their profession. Further, the professional life of the resident or any physician in question will generally not be compromised legally because of their addiction if they consent to and successfully participate in treatment. Most physicians' health programs have agreements with medical societies. If they identify the problem, and if they can assure that the physician receives appropriate treatment and monitoring to prevent a recurrence or relapse, the licensing board will usually not revoke the license and preserve confidentiality about the issue. Physician health programs can be of enormous help. The key components of a physician's health program consist of evaluation, referral for treatment, aftercare, and monitoring of the physician. Once the individual has been evaluated and referred by the physician's health program, treatment proceeds on an individual level of need. For example, some addicted physicians may require referral for detoxification, which calls for inpatient care. That is then followed by a program conducted either on an inpatient or outpatient basis that deals with the issues of addiction, including denial and rationalization. Program resources range from groups like Alcoholics Anonymous to Women for Sobriety to individual therapy sessions. Success rates appear to be higher when they are treated within their peer group. Not all residents need inpatient treatment. If that is the case, the physician is treated on an outpatient basis until the addiction is resolved satisfactorily. In some settings, a physician's health program may communicate directly with the program director. In others, it may report to an intermediary group, such as a hospital employee health service, that in turn communicates fitness for duty decisions to the program director and oversees any necessary monitoring. The program may wish to place the resident on a leave of absence until it has been determined the resident is safe to return for full duty. The program may also be able to arrange a reading elective or non-clinical experience with appropriate supervision. Once the physician is rehabilitated and able to safely resume his or her duties, an outpatient aftercare program for monitoring is devised. This includes a contract that outlines the recovering physician's intervention goals, continued meetings and counseling sessions, as well as random or scheduled drug screens. Modifications of the resident's schedule may be desirable upon return to duty. Close supervision and monitoring is essential as outlined in the contract. The prognosis for addicted physicians is good. They are highly motivated because of licensing issues. Outcome studies show 75 to 95% success rate at 2 to 5 years, which increases with monitoring. In one study, researchers show a 96% abstinence rate after an 8-year follow-up period when monitored by random urine drug screens, as compared to 64% for treated but unmonitored drug screens. On re-entry to the residency program, monitoring should be aimed not only at the resident, but also at the specific resident performance measures, which include the quality of patient care the resident delivers. Re-entry may offer particular challenges to the resident in addition to resuming duties and staying substance-free. Many experience guilt due to their absences and humiliation because of their addiction. For this reason, it is important that the program director maintains a therapeutic and non-punitive environment. Residents may want their problems to remain confidential. Others may want to share their experience with their colleagues. Either option should be supported.
I was worried about getting back into the swing of things. When I left for treatment, I more or less had to dump all my duties on the shoulders of my colleagues, and they had to take up my slack. When I came back, they had to take up slack because I needed to make time for counseling sessions, show up for monitoring, things like that. I was also worried about what they knew, about how they felt about everything, my addiction and all. Well, you know, everybody seemed as nervous as I was. It was kind of funny in a way. But they seemed glad to have me back. As glad as I was to be back.
Substance abuse can occur in residents during their training periods. Should that occur, it is important that institutions have strategies in place to help identify and treat residents with problems. An organized plan to address the issue is imperative. A clear policy on substance abuse and a defined process for addicted residents to assist them in their recovery will ensure that he or she can resume training as a drug-free professional.